Look at these two clinical presentations. Patient A presents with fiery red, swollen gingiva, while patient B has pink, firm, fibrotic tissue. When a periodontal probe is inserted, both patients register a 5 mm probing depth. These identical 5 mm readings represent entirely different structural realities. A common clinical error is to assume that matching measurements indicate an identical disease state. Probing depth acts as a measurement of physical geometry, the distance from the gingival margin to the base of the sulcus, rather than an indicator of periodontal disease severity. The boundary between gingivitis and periodontitis depends on the physical integrity of the periodontal attachment apparatus. This distinction forms the basis of the 2017 AAP-EFP classification for periodontal and peri-implant diseases. According to these 2017 criteria, dental biofilm-induced gingivitis requires the presence of biofilm and bleeding on probing at 10% or more of sites. However, the diagnosis also requires a strict measurement of zero clinical attachment loss. Alongside zero attachment loss, there must be absolute zero radiographic bone loss to qualify as gingivitis. Relying on pocket depth rather than attachment loss leads to misdiagnosing a reversible inflammatory condition as an irreversible destructive disease. The 1965 low experimental gingivitis model proved that withdrawing oral hygiene initiates clinical inflammation within 10 to 21 days. A dysbiotic shift drives this disease. Withdrawing oral hygiene replaces commensal gram-positive bacteria with gram-negative anaerobes like Fusobacterium nucleatum. They release lipopolysaccharides and enzymes that migrate across the epithelial boundary into the gingival tissue. The host's innate immune system detects these bacterial products, triggering the release of inflammatory cytokines, including IL-1, PGE2, and TNF-alpha. These released cytokines cause an immediate increase in vascular permeability, initiating the physical breakdown of the local tissue. The shifting architecture of the biofilm dictates a cytokine-driven immune response. This active host defense is what ultimately breaks down the gingival structure. The Page and Schroeder continuum maps subepithelial destruction. The initial lesion, days 2 to 4, features PMNs migrating into the sulcus. By days 4 to 7, the early lesion begins. Lymphocytes dominate, and the supporting collagen network fragments. During the early lesion, 70% of the collagen in the infiltrated area is degraded. This combination of collagen loss and increased vascular fragility causes bleeding on probing, the earliest objective sign for diagnosis. The established lesion appears after 2 to 3 weeks, with plasma cells dominating the immune response. The gingival margin swells outward as edema increases, and more collagen is lost. Even with this internal collagen destruction and outward swelling, the deep architectural foundation of the tooth remains untouched. Edema pushes the gingival margin coronally over the enamel, unlike periodontitis, where tissue migrates apically. This creates an illusion. Probes on both sides register 5 mm, the left due to upward swelling, the right because the probe drops below the cemento-enamel junction. The differentiator between these two states is the apical extent of the junctional epithelium. In a pseudopocket, the junctional epithelium remains attached at the cemento-enamel junction. No apical migration has occurred. Beneath the epithelium, the periodontal ligament and alveolar bone crest remain healthy and intact. This differs from true periodontitis, where the junctional epithelium has detached and the crestal bone has been resorbed. Radiographic confirmation of a pseudopocket shows stable crestal bone positioned exactly 1 to 2 mm apical to the CEJ without angular defects. A deep probing depth without attachment loss or bone destruction is a geometric illusion caused by coronal swelling. This is a pseudopocket. Because the bone and periodontal ligament are intact, the established lesion is 100% reversible. This reversibility makes non-surgical periodontal therapy the primary intervention. Professional mechanical plaque removal uses specialized ultrasonic and hand instruments to thoroughly disrupt and remove the subgingival biofilm. The patient must also perform daily cause-related therapy, specifically the modified Bass technique and interdental cleaning. Chemical adjuncts like chlorhexidine 0.12% serve as second-line short-term tools. as long-term use leads to tooth staining and taste alteration. When systemic factors like uncontrolled diabetes or pregnancy hormones are present, mechanical therapy is paired with host modulation or physician consultation. Since the condition is biofilm-induced, physical disruption of that biofilm remains the only definitive cure. Phase 1 therapy concludes with a mandatory reevaluation 4 to 6 weeks later. Removing the biofilm allows the immune response to halt and the edema to subside. Fibroblasts reestablish the collagen network, and the gingival margin returns to its normal position at the cemento-enamel junction. The tissue returns to a firm, pink, scalloped contour, and the pseudopocket depth naturally drops to 3 mm or less. If the reevaluation shows bleeding on probing at less than 10% of sites, the patient has achieved clinical gingival health. Failing to intervene during the established lesion phase leads to permanent damage. Prolonged inflammation eventually triggers osteoclast activation, marking the transition to periodontitis. Gingivitis represents the final opportunity for total clinical reversal. By prioritizing clinical attachment loss over pocket depth, clinicians can identify the pseudopocket and intervene before the disease becomes irreversible.